Hi, Dr. Flamm. Thank you for joining us on MD Newsline. And I know we've talked about this before, but can you tell us what MASH is?
Yeah, that's an excellent question because one of the big problems in the United States and around the world is a problem that, in my world, as a liver doctor, a hepatologist, we call fatty liver or MASLD. That stands for Metabolic Associated Steatotic Liver Disease. A normal liver doesn't have any fat or virtually no fat. But it turns out that approximately 30% of the entire United States population, or 100 million people, have fat in their liver where it doesn't belong. And again, we call that MASLD. Now, a fraction of those patients, and we don't understand why, get inflammatory cells in the liver. These inflammatory cells in your body go into the liver when there's fat there and attack and create true damage in the liver. That problem is called MASH. Now, it turns out that about 25% of the people that have fatty liver or MASLD have MASH. 25%. Now, you can only determine if someone has MASH if you do a liver biopsy, which we usually do not do. But it's still very important because it turns out that the patients with this hepatitis, with these inflammatory cells in the liver, MASH, they are the ones that are at risk for true damage to the liver, which we call fibrosis. Those are the patients, if they get more and more fibrosis over time, can get cirrhosis, get complications of cirrhosis, and die from liver disease. So this is a very common problem. Only a fraction of the patients get this hepatitis. Only a fraction of patients develop cirrhosis, but it's still a significant number of people in the United States. And by the way, if you said, how do you even know if you have fatty liver? It's so many people. You can see it on imaging. If anybody gets an ultrasound or a CT scan or an MRI that includes the liver, you can see the changes that we call steatosis, which is the medical word for fat.
So that's a lot of people with fat on their liver. How do some people develop fat on their liver and some people don't? What makes people susceptible to that?
That also is a great question. We're working on that in the clinical research world every day. And we have been, I would say, that for the past 20 to 30 years since this liver problem became apparent. And we don't know all the answers. We do know that fatty liver is almost always associated with at least one of three conditions. People have high cholesterol and or triglycerides. People have type 2 diabetes mellitus, or people are overweight. And it turns out many of the patients with this have all three of them. So we know clinical conditions that lead to the development of this fatty liver. Exactly how it happens, we don't know. We know that insulin resistance, which is what we see with type 2 diabetes mellitus, by the way, is one of the big drivers of developing fat in the liver or steatosis. We know, although we don't have it well characterized yet, that genetic factors almost certainly play a role, and the medical community is working very hard to try to ascertain what genetic factors seem to contribute to the development of fatty liver in the first place, and then the development of the steatohepatitis in the fraction of people that get it in the second place, and then developing liver fibrosis, damage in the liver, in the third place. But we don't yet have a very good characterization of the genetic underpinnings yet of all of these different factors that lead to progressive liver disease from fatty liver.
I definitely want to get to some of the comorbidities, but would you say that most people with fatty liver never end up being seen by a doctor about it?
Well, yes, that's totally true. 100 million people we think have it just in the United States. The estimates are in the world that 2 billion people have it in the world. It's an incredibly common problem. And you can only diagnose it, as I said, with imaging. And people don't always get imaging. I've never had an ultrasound or a CAT scan yet. Maybe I have fatty liver. I don't have the risk factors for it, but I would be a person like many that might have fatty liver and yet doesn't know it, so they don't see a provider. But there's no more recognition of this around the country now, and primary care doctors are starting to understand these risk factors for fatty liver. Endocrinologists who take care of people with type 2 diabetes mellitus are starting to understand the risk factors in the presence of fatty liver. Cardiologists, because many of these patients have coronary artery disease, they're starting to recognize the presence of fatty liver. So many of the stakeholders out there, the providers that take care of patients on the front lines, are starting to know that fatty liver is a thing, and that if they do get an imaging procedure and see it, that they identify it and then refer the patient to a gastroenterologist or a hepatologist for extra evaluation.
Interesting. So let's talk a little bit about comorbidities and comorbidity management. You mentioned things like diabetes. I'm wondering about cardiovascular risk. How does the cardiovascular system get impacted by MASH, and how do we kind of gauge the risk between people with just regular fatty liver and people with more advanced MASH?
Again, fatty liver is a very common disease, and we have a very good understanding of how people die later when they're diagnosed with fatty liver. Now, the audience might think, well, gee, if you're diagnosed with fatty liver, the reason that people might die is from liver disease. And it's true, some do, but it's not even close to the number one cause of death in people that have fatty liver. The number one cause of death in patients with fatty liver in general is actually cardiovascular problems. That's number one. Number two, by the way, still isn't liver. Number two is non-liver related cancer. Non-liver related cancer, gastric cancer, colorectal cancer, pancreatic cancer, even breast cancer is increased in people with fatty liver compared to matched people that don't have fatty liver. And third on the list, actually, in people for cause of death that have fatty liver is actually liver problems, liver disease. So it's very important for providers out there, even GI and liver providers who see patients with fatty liver, to keep in mind that these other problems cause death even more commonly than liver disease, and that these patients need very, very aggressive therapy of these other issues to hopefully prevent the increase in mortality that you see. Now, you mentioned to me cardiovascular issues specifically, and the reason is that the factors again that are associated with fatty liver are type 2 diabetes mellitus and cholesterol and triglyceride problems. And these, of course, are risk factors for coronary artery disease. And we didn't mention, but hypertension is also often seen in patients with fatty liver. It is not a driver itself of the fatty liver, but it's seen in association with all of these other problems that patients have. That, in fact, is why it's called metabolic associated steatotic liver disease, because many of these people have the metabolic syndrome, which includes hypertension, diabetes mellitus, and cholesterol issues. Now, these, of course, are all factors for the development of coronary artery disease. So providers, again, that see these patients must keep in mind that patients that have these other risk factors, these other problems associated with metabolic syndrome, should be seen and evaluated by appropriate providers and have very aggressive medical management of these other problems.
You said a lot of interesting things there. The first one I want to touch on is, why is there an increased association with people who have MASH and gastric, colorectal, pancreatic cancer? Is that just a correlation, or is there some sort of causal or amplifying relationship that we know of?
Well, presumably there's a causal relation, but uh, to my knowledge, we do not know the reason. But it's been documented in multiple studies, and it's an accepted thing in the world of people that take care of fatty liver. So you have to be very careful in women that have this to do mammograms for breast cancer screening. You have to be very careful with men and women to do colorectal screening. These types of things that we already are supposed to be doing. They're particularly important in people that have fatty liver because of this slight increased risk.
I wonder, does fatty liver cause hormone changes or anything else along the lines of, body processes? Do they heal slower from wounds? Does it have any of those
Yeah,
effects?
I don't know that fatty liver itself causes hormone changes or healing changes. Now, of course, if you're cirrhotic and your liver is very, very damaged for any reason, including fatty liver, you can certainly have problems with wound healing and hormonal changes from the cirrhosis and the development of end-stage liver disease. I'm not sure if fatty liver specifically, outside of the development of cirrhosis, actually impacts that stuff.
Gotcha. Let's talk a little bit about hypertension. Are there any specific anti-hypertensive agents that show a benefit in reducing fatty liver, liver fibrosis or inflammation in MASH patients?
I've not heard of any specific antihypertensive agent that is better than another. The most important thing for the cardiovascular risk that these patients have is to be on some agent or some group of agents that keep the blood pressure down, because you really want to mitigate the risk factor for having a myocardial infarction or a stroke. So I don't think there's a specific agent in the hypertension world, but aggressive management of hypertension is very important.
When it comes to obesity management, when do doctors start to consider anti-obesity medication specifically for MASH patients?
That's another great question. You know, many studies in the world in people with fatty liver all around the world have demonstrated that one of the most effective therapies of fatty liver is weight loss. Weight loss. And it turns out that if patients lose 8 to 10% of their body weight, 8 to 10%, the NASH, the steatohepatitis aspect that they have that we think drives fibrosis, can actually resolve. And fibrosis, the damage to the liver that we previously thought was irreversible, can sometimes even reverse. So weight loss is a critical, critical recommendation for patients that have fatty liver. Now, of course, weight loss is very difficult. The older you get, the harder it is to lose weight. When I have patients that have morbid obesity and they are diagnosed with fatty liver and they come to see me and they're sitting there and I tell them that weight loss is a very, very good idea, they don't look at me and say, "Oh my goodness, what a great thought. How did I never think of that?" They all have, of course, been trying to lose weight most of their lives, and it's extremely difficult. It's difficult for anybody, but it's very difficult for them. So when patients have fatty liver, it is a very good idea for physicians to consider ways to help patients lose weight. And that can include medications, that can include procedures like a gastric sleeve, bariatric surgery, gastric sleeve, or gastric bypass surgery. That can include behavioral therapies for them to try to help with weight loss. So there are many avenues for patients to try to help them lose weight if the patient is invested in trying to lose weight.
What are some of the go-to medications that we can describe that what are some of the go-to medications that doctors prescribe when it comes to helping patients lose weight?
Yeah, there are medications that have been used for weight loss for quite some time, which we try, like phentermine and orlistat and other medications like that. Then there are some of the newer medications, the GLP-1s, for instance, the medicines that have the dual effect of helping with weight loss and helping with type 2 diabetes mellitus, two of the three reasons people get fatty liver in the first place. And they are very promising, by the way. Now, if you said, are they approved for the fatty liver part for these patients? The answer is, as of now, no. But there are phase 3 trials ongoing right now looking at various GLP-1 medications, specifically looking at the fatty liver aspect that they are potentially treating. And I can tell you the results to date are very, very promising. So certainly, I think if a patient has type 2 diabetes mellitus and they're overweight, I do recommend right now for patients to follow up with their primary care doctor or their endocrinologist, and that if it's appropriate for a particular patient, that a GLP-1 medication is considered, because not only does it help their diabetes, not only does it help their weight loss, but at least in preliminary studies, it seems that it will help their fatty liver as well.
Are we finding that patients are mostly coming in already on GLP-1s? And since it hasn't been approved for fatty liver, if they aren't already on GLP-1s, how does that, uh, I'm guessing they would have to be prescribed that elsewhere, not in the.
Yes, some of them come in on GLP-1s just because they're so commonly used now. And when patients have type 2 diabetes mellitus and are overweight, their doctors understand that it will help those two things. But many, many, many patients have type 2 diabetes mellitus and are obese and are not on those medications. Sometimes because the medications are difficult to obtain. Insurance is not, certain insurances are not that supportive of those medications right now. And other times because the doctors don't really, their providers, I don't know if they recognize the benefit. So again, in my notes to providers, many times, if a patient is appropriate, state that a GLP-1 might be considered by a primary care physician or an endocrinologist in patients with those factors, if their provider thinks those are appropriate medications, because they might have benefit to their liver also.
Are statins effective for MASH patients, especially those with advanced fibrosis?
I'm glad you asked that, because I'm going to change the question a slight bit. Because, when statins were first developed 30 plus years ago, there were very grave concerns about liver toxicity. Now, those have almost all been dispelled. They've almost all been dispelled. And there are numerous papers out there for many years that statins are safe in patients with chronic liver disease. They're safe. And I still get questions about once a week or once every 2 weeks from doctors. Can I give a statin in this patient? They have a liver problem when they have fatty liver. And the answer is always yes, unless the patient has a known reaction to statins, which is very, very rare. I think in my entire career, I've seen 1 or 2 patients that have had a liver toxicity from a statin. And these are amongst the most commonly used medications in America for decades. So you can use statins. And keep in mind, the patients with fatty liver die most frequently from coronary artery disease or other cardiovascular problems. And it is very important to treat their cholesterol problems appropriately. And statins are often thought to be the best medications for that. Now, do statins specifically help the liver directly? And that has not been demonstrated yet. We don't have data that show that statins specifically help the liver. Now, we do think helping cholesterol and triglyceride problems help the liver. And yet, to my knowledge, I'm unaware of studies that demonstrate that statins specifically help the liver in patients with fatty liver. But it still helps patients who have cholesterol issues. And, an aggressive therapy with statins often is a very good idea for patients.
When it comes to off-label treatment, should metformin be considered for non-diabetic patients with MASH, given its potential effects on insulin resistance and inflammation?
Yeah, that also is a great question. Metformin was thought potentially to help people with fatty liver. It was one of the first drugs that was really investigated in fatty liver years ago, because from a theoretical standpoint, it would seem that it could help. It helps type 2 diabetes mellitus by helping with insulin resistance, and these again are thought to be drivers for fatty liver. And yet, metformin really never demonstrated efficacy for the fatty liver part. So metformin is not recommended for treatment of fatty liver. Now, if somebody wants to use metformin for type 2 diabetes mellitus, you can for that. But we don't think it actually helps the liver part.
Interesting. So let's talk about the gut. Does the gut have play a role when it comes to fatty liver or any other aspects of treating MASH?
In the last 10 years or so, it seems like the gut microbiota have impact on many, many, many medical conditions. And we really still don't understand that this is in general. Now, again, I work in the GI liver world, so I focus on the gut microbiota, and the gut is in the GI world. So it's something that we in our practice consider. But still, the exact impact that gut microbiota have in liver disease in general and fatty liver in particular, it's not really well characterized yet. They're working on it too. They're trying to figure out if there's an impact, if there is, which particular microbiota are favorable and which particular microbiota are unfavorable, because perhaps in the end we'll have tailored therapies that can kind of change the microbiota in a favorable way to actually help long-term outcomes. But as of yet, not really well understood all the different aspects.
And with that in mind, what do we know yet about biomarkers or genes when it comes to tracking or even understanding MASH better?
Yeah, I mentioned at the beginning, 100 million people seem to have fatty liver, but only 1/4 of them get this hepatitis. And out of the people that get the hepatitis, we think about 1/4 of them will develop substantial fibrosis and cirrhosis. So in the end, if 100 million people have fatty liver in the United States, 25 million have MASH, and out of those, a total of 5 million people, we think, give or take, will have cirrhosis, either current or soon. And the question, of course, is why? Why do 100 million people have a problem and 5 million people have a bad problem from it and the other 95 million don't, at least liver wise? Presumably genetic factors. So people are trying very hard to really investigate various different genetic factors in patients with fatty liver that seem to either be protective or more destructive. And there have been a few, PNPLA3 is one, there have been a few genes that have been identified that seem to predict a more aggressive course of fatty liver and worse outcomes. But still, we do not have anything near a very good idea of the genetic underpinnings of predictors of outcomes, either good or bad, in fatty liver. We do not have any recommendations to check any genetic profiles yet in fatty liver. Now, if you said, Dr. Flamm, what do you think is going to happen 10 years from now? Of course, it would be speculation on my part, but it wouldn't be a surprise at all to me if we do have a genetic analysis, a genetic set that we check to try to help patients with their prognosis. We may even have different therapies that are directed to different genetic abnormalities by then. But as we sit here now, uh, work is being done, but no recommendations for genetic testing.
Mm. So are some current what's some of the current evidence supporting the use of things like vitamin E or other antioxidants in non-diabetic MASH patients?
Yeah, like in many medical conditions, we think oxidation issues might be the cause of some of the bad outcomes that patients have with very many diseases. And it's true with the liver too. And one of the antioxidants that has some efficacy and is readily available and isn't very expensive is vitamin E. And there was a study in fatty liver and what we then called NASH, but is now called MASH, in non-diabetics called the PIVENS trial, PIVENS, and the NS part was NASH, and the VE part was vitamin E. So vitamin E was looked at in a placebo-controlled trial in NASH in non-diabetics and non-cirrhotics too, by the way. And it did have some efficacy. Um, and vitamin E in the recommendations is listed as something to consider in a non-diabetic, non-cirrhotic NASH patient because it did help short-term outcomes. But, many physicians don't really use that anymore, I would say. Uh, so there may be some role in selected patients
Right.
with MASH.
What is the most significant source of oxidative stress in MASH patients, and how can that be mitigated?
Yeah, that's a great question too. Again, in my understanding of the literature, very poorly understood. What are the drivers of oxidative stress? That's the term we use. Again, for many diseases, fatty liver is one, that we think is critical for the development of true damage in the liver. Because, of course, if you could identify those drivers of oxidative stress, you would eliminate them if you could, and you would also develop therapies to combat them. But not great understanding yet of the drivers of oxidative stress that cause damage in the liver. Again, maybe 10 years from now, we will have some better understanding, but not yet.
I want to round out just talking about your direct communication with patients. How do you explain kind of the difference between the they're both pretty bad of fatty liver and then the more advanced stages of how do you explain the differences between these two things to patients, and what are you finding is kind of the biggest hurdle when it comes to getting patients to understand where they are at with their health?
That also is a great question. One of the many factors that I think impact the relationship between a doctor and a patient and their outcomes uh, is the communication that a doctor or any provider has with the patient. When patients come to see me or come to see any provider, I always say they want to know four things,
Mhm.
all of them. I don't care what provider. You want to know what you have, you want to know why you have it, you want to know how bad it is, and you want to know how to fix it. And maybe a fifth is how are you going to follow me over time? Those are the things you want to know. So I spend a significant amount of time talking about, like I just did on this podcast, talking about what this actually is, this problem. And I talk to them about why they have it, the factors that lead to it. I then tell them we need to figure out if you have fibrosis, which is damage in the liver, or not, because that will help me with your prognosis. And then I tell them how to fix it, which is usually weight loss, abstaining from alcohol, treatment of type 2 diabetes mellitus if they have it, and treatment of their cholesterol triglyceride problems if they have it. And I do that with every patient. And I think it really helps them. It makes them more comfortable because they understand the problem. And it makes them more comfortable because they know what they need to do about it. And it makes them more comfortable because they know how I'm going to follow them. When you read the internet now, which everybody does, patients and doctors and providers too, as a matter of fact, a lot of the stuff on the internet about medical diseases is bad. People that are doing great with medical diseases usually are not on the internet writing testimonials. The people that are on the internet writing testimonials are people who are doing poorly. So patients, in my experience, who have a disease like fatty liver, when they read the internet, they get a very kind of a biased look as to what is going to happen to them. And I try to correct that. And it usually makes them feel much more at ease and much happier and much more secure and much more confident. And I tell them that we have a chance to actually reverse this, fix this, and that the long-term outcome can be very good.
Do you find that patients are usually good at following the care regimen that you recommend, or do you meet certain resistance with patients?
Yeah, I don't get it's a good question. I mean, do they follow? They follow up. They do the lab tests they need. If patients have cirrhosis, they're supposed to be getting ultrasounds every 6 months for liver cancer screening because there's an increased risk of liver cancer. Don't forget that if you're a provider. And the patients follow that. They have great difficulty, in my experience, is in terms of weight loss. And some of that's our fault, my fault, because we really need to engage patients in proper uh, disciplines, looking at this as a multidisciplinary disease to actually help them. We say to patients, lose weight. Again, I mentioned this before. This is not the first time the patients have thought of this. They've tried already. So it would be helpful for me and other providers probably to try to engage them with other providers that can help them with weight loss and be more aggressive with that. And some patients have trouble with the alcohol abstinence recommendation. Many abstain from alcohol use when they find out they have chronic liver disease, even if it's not from alcohol, because alcohol in the setting of liver disease from something else isn't good either. But some patients have trouble with this and they continue to consume alcohol. So, we do the best they can. I find most patients engage. How successful they are, can vary.
The last question, the abstinence from alcohol, just this is completely, they can't have any alcohol whatsoever.
I mean, truthfully, they can have an occasional drink. But I can tell you, the more they drink already, the less they should have, that they should abstain. If somebody says, "Doc, I have a glass of wine once a month," if they don't have cirrhosis, that isn't an issue. Now, if somebody drinks on a more regular basis or more substantial basis, those patients should abstain from alcohol use because they don't have one drink a month. They have more than that. And and you have to kind of be more aggressive with that. There's a component of MASLD, Metabolic Associated Steatotic Liver Disease, which they call MET-ALD. That's metabolic syndrome, which is the fatty liver part, and it's alcohol-related liver disease in one patient. So if you think a patient has risk factors for fatty liver and drinks a substantial amount of alcohol, that's more of a combined picture. And there happened to be a lot of research ongoing for them because those patients are a little different than the people that have pure MASLD
Mhm.
and MASH.
Does their ability to completely abstain impact their eligibility for treatment at all?
Yeah, in the study that was done with resmetirom, which is the one approved drug for treatment of MASH and patients who have stage 2 or 3 fibrosis specifically, patients could be in that trial that drank up to 2 drinks a day, actually, which is a lot. So the data show that that drug has benefit, for instance, in patients with fatty liver who have up to 2 drinks a day. So technically, if patients have up to 2 drinks a day, and if they're otherwise a candidate for resmetirom, for instance, we would use it. If they're drinking more than that, then I think the balance starts to tip to alcohol-related liver disease, and you might not want to treat them the same way.
Well, thank you, Dr. Flamm. This has been an excellent conversation. I can't wait to talk to you again when something new, hopefully, emerges in the world of MASH and treatment. But it's been a pleasure having you as always.
Thank you so much. Thanks for the interview.